Hello, everyone. My name is Miguel Divo. I'm a pulmonary critical care doctor from the Division of Pulmonary Critical Care at Brigham and Women's Hospital. I'm going to be talking to you about treatment of COPD, including exacerbation. For this lecture, I don't have any conflict of interest, although I'm going to be talking about specific treatments, but I will make sure to have a balanced lecture and be of any commercial bias. To start this lecture, I'm going to talk about the 10 COPD commandments. We have guidelines, and this is one reference that I would like to refer to all of you regarding how to deal when we have complex guidelines that are complicated. And this is a nice reference. And this guidelines, or at least this reference, talks about prevention, diagnosis, treatment, and monitoring. In this lecture, I'm going to talk about prevention and treatment, and I will go to all the subsets. In previous lecture, you have seen the assessment for COPD, but this will have a little review on that in order to better understand how to treat this disease. So the goals of COPD management is going to be related to relief of symptoms, improve exercise tolerance, improve quality of life, prevent and treat exacerbations, prevent disease progression, if we can, reduce mortality, and assess comorbidities. What we know with all the evidence that we have found up to today is that the relief of symptoms, improvement of exercise, quality of life, and the prevention of exacerbation is something that we were able to act and have improvement. However, prevention of disease progression and reduced mortality has not been proven except for very specific treatment, which I will speak of. But pharmacologically, we have not found this silver bullet. And the assessment of comorbidity is important because this is a very complex disease. In which sense is a complex disease? And this is an important graph that I will go back after reviewing treatments that are specific for COPD. As you can see here, there is a graph that will show time and volumes. And what we have here is the classic time volume chart for obstruction. And what we can see is normal curve for people who can excel forced vital capacity. And on the first second, they can excel more than 70% of the total vital capacity. However, for COPD, and the definition of COPD is that there is obstruction. Although obstructions, what we have is a mixture of different diseases that makes this more a syndrome than a single disease. So as you can see in this graph, there is an overlay or a Venn diagram where in this dotted box we have airway obstruction as just defined, and here we have an emphysema, alpha-1 antitrypsin, chronic bronchitis, asthma, and COPD overlap with or without high eosinophilia, and a very important subgroup that we tend to under-recognize that are the never smoker with airway obstruction. All this is in a single bag called COPD, and this is important at the time of differentiation of treatments. So let's first go with prevention, because there is an important part of what we are going to be seeing in our day-to-day practice. And we'll start with elimination of smoking. And what we know about smoking cessation is very difficult. In this graph, I'm showing a study that was published in 2009 when we are comparing three medications, placebo versus bupropion that was used classically for antidepressant medication, and varenicline. And varenicline, it's one of those medications that was launched for the smoking cessation. And as you can see is that on the evolution of the study that was seen a follow-up of 1 year, varenicline was superior to bupropion and placebo in the continuous abstinence. What is sad is that at the end of 1 year, only 25% of the patients were abstinent of smoking cigarette. What else is important is that with this medication, a lot of people declined or left and jumped or just stopped the varenicline because of the side effect. Nausea, insomnia, and GI symptoms are the most important ones. Most lately, we have a lot of controversy about e-cigarettes. And what we have is the consensus study report by the National Academy of Science, Engineering, and Medicine about the e-cigarettes. E-cigarettes is a liquid in form of oil with nicotine that is vaporized, and it has been suggested that it can be a substitute for the actual cigarette or smoking. So what we know and the evidence of this report is the following. Electronic cigarettes are less harmful. Some people are saying more safer, but I will say less harmful than tobacco cigarette. But this is a double-edged sword because also we have that the adolescent user of e-cigarette were 7 times more likely to non-user to smoke conventional cigarettes in the future. And this is a key point about how to promote this therapy. If you have somebody who has difficulty in quitting smoking, this can be an alternative as it's less harmful as the tobacco. Then we'll go to other 2 treatments. We then tend to overlook them, but they are a very important part of the integration of COPD treatment. One is the promotion of vaccination, and the other is promotion of exercise. How we want to do that? Well, promotion of vaccination, we know about the influenza virus, but more importantly, I want to concentrate on one thing, which is pneumococcal vaccination for smokers and patients with COPD. And what we have here are 2 versions of the vaccine. So we have the 23-valent pneumococcal polysaccharide vaccine, or PPSV23 Pneumovax 23, and the 13-valent pneumococcal conjugate vaccine, which is the Prevnar 13. And what we know is that for everyone who is a smoker or patient with COPD, we can vaccinate them at age 19 to 64 with the Pneumovax 23 or the PPSV 23. We need to just wait 1 year, at least 1 year apart, to give the Prevnar 13, and then 1 year apart to reinforce with a 23 after age 65. And this is a chart that you can find at the cdc.gov webpage, and this will help us to better establish how, in this particular population, we need to have vaccination at early age. The second part of that is rehabilitation. And what we know about pulmonary rehabilitation. Pulmonary rehabilitation is an integral part of the treatment. And what we know is that although it will not improve lung function, and this is not meant to improve lung function, it does increase exercise tolerance, reduce dyspnea, and improve quality of life. Also, there are other elements of this therapy, that is education and better use of inhaler therapy. Now we're going to treatments, and on the treatment we're going to institute specific therapy, and here we're going to talk about pharmacotherapy and then also how to use correctly inhalers. So let me start first about the smaller airway cross-section. What is the logic and what is the understanding of why we use therapy for COPD? First of all, we know and we spoke about obstruction, and this is a cross-section of a smaller way of a normal patient with, or a normal person and a COPD. And what we have is there is a significant decrease in the lumen of the airway that causes obstruction. Part of that is because also we have a fibrotic process around the airway. On top of that, there is mucus production, and what we see also is that there is constriction of this small smooth muscles of the small airway as well. We see that there is some lymphocyte follicles there, which can cause inflammation, or at least they're associated. And there is area of the lungs that are empty or destroyed, and that is emphysema, or we see that as emphysema. So the treatment targets are going to be, as seen in these slides, for the airway constriction, we're going to use bronchodilators. We're going to act on the smooth muscles of the airways. Also, some of them can decrease the production of mucus. For the inflammation part, and those patients who in particular are more susceptible, not all COPD, we're going to use steroids. And last, for those patients with severe destruction, which is emphysema, we have oxygen. If they are alpha-1 antitrypsin deficiency, there are certain options for that, or lung volume reduction surgery. So from the bronchodilators, we started historically with only 2 mechanisms, and now we have a plethora of different inhalers. So I'm going to try to take you to this course of the new inhalers in a easy to remember way. So why and how we're going to better understand bronchodilators: 1, by the mechanism of action; 2, the dosing frequency; single or in combination, the route and delivery system. And that is a nice way to identify and better understand each one of them. So what is the biologic background behind it? If we take this oval, which is the smooth muscles, we have 2 types of receptor. One of the receptor is the beta-2 receptor, for which if we act under this receptor, we're going to have smooth muscle relaxation, and that is the beta-2 receptor, and that's why we use agonist. On the other hand, if we block the acetylcholine N3 receptor, then we're going to have relaxation. And if we have acetylcholine, they're cause of smooth muscle contraction. And for this, there are other medications that also will act. We have also the phosphodiesterase inhibitors, which also will act on the smooth muscle. So we have 3 different mechanisms according to 3 types of receptors that we are going to act directly on the smooth muscle. And what we have here is the next is the pharmacokinetics. So we have short-acting, meaning those are medications that will act and have a half-life of around 6 hours, 4 hours to 6 hours. Those are the short-acting medication. We have the long-acting medication, half-life of 12 hours, so we use every 12 hours. And then we have the ultra-long-acting, which is given once a day. And that will help us to start to establish this nice grid of the different type of medication. 1, mechanism of action; 2, frequency. So here we have a table that help us a little bit understand that. By the mechanism of action, which is the top row, we have inhaled corticosteroid, ICS, beta-2 agonist, and muscarinic antagonist. And then on the first column, we have the dosing frequency: short-acting, long-acting, and ultra-long-acting. And when 2 of those medications are together, is because a formulation with a combination of those 2 pharmacologic agents exists in the market. In other words, fluticasone and salmeterol here are both medications that exist in the market as a combination. So you can see that there is ICS with beta-2 agonist, ICS alone, beta-2 agonist alone, or in combination, and in combination with also muscarinic antagonist. And more recently, there start to have approval for triple therapy where there is ICS, or inhaled corticosteroid, beta-2 agonist, and muscarinic antagonist. So on the ICS side, we have long-acting Q12 hours, fluticasone, budesonide, beclometasone, and triamcinolone. And this is some of the most important ones that we have here in the US. We don't tend to use them alone for COPD patients, so we have it in combination. And the combination, it comes as ICS, inhaled corticosteroid, and beta-2 agonist. And we have fluticasone salmeterol, budesonide formoterol, and fluticasone vilanterol. And then we have the mechanism of action, the muscarinic antagonist, ipratropium, aclinidium, tiotropium, umeclidinium, and glycopyrronium, and the combination with the beta-2 agonist, as you can see in this table. How we put all this together? So we have short-acting, or also called reliever, and here we have certain pictures and descriptions. This is coming from a nice poster of the Lung Association of Canada. We have then controllers or medication that are long-acting and ultra-long-acting, and we have as inhaled corticosteroid alone. We have long-acting bronchodilators. On the top side, we have the beta-2 agonist, or LABA, L-A-B-A, LABA. We have the long-acting anticholinergic or long-acting muscarinic antagonist, LAMA, on the bottom here. And then we have the combination ICS-LABA, so inhaled corticosteroid, long-acting beta-2 agonist, combination of LABA and LAMA, which is long-acting beta-2 agonist with a long-acting muscarinic antagonist. And that is a nice way to populate, and more medication coming, so be ready. And now we have this plethora. So what is the evidence? Well, bronchodilators do the work, and this is, I'm using only one example of using of tiotropium of this UPLIFT study. They do bronchodilate, and as you can see here is on 5,000 patients, and 5,881 patients with an average of FEV1 of 1.1, what we can see is the pre-post differential of the FEV1 and how many patients in average have no changes to up to 300 mLs gain after the use of tiotropium. This is a pre-post, and this is the post and the differential and the gain. And as you can see, more than 53 or around 53% of all the patients have at least 200 mLs gain after the use of the inhalation. So it works on 53% of patients. And what we can see is the gradient. Also, we can see that sometimes there are people who bronchoconstrict, and we don't consider that, but this is something that we need to take into account. And maybe those are the patient that needs another type of medication. Just keep that as a potential consideration. The next slide shows that ICS alone do not are as helpful as you can use it in asthma for the treatment of COPD. And what I'm trying to show here is from the TORCH study is that if you have placebo, which is the lower curve here, the bronchodilation is lower and the number of mLs per year lost in a 3-year period of follow-up, 6,000 patients, it's more on the placebo. On the top line, we have the combination of salmeterol and fluticasone. It's a combination in inhaled corticosteroid with a long-acting beta-2 agonist. And if we take the two separate elements, which is salmeterol or fluticasone propionate, the combination of the two is more powerful than each one in separate. And this is what I'm trying to show here. The only problem also that we see is that although the number of mLs per year that have been lost in the 3 years follow-up in this study do not reach statistical significance or clinical significance of changing the progression of disease, but definitely is a sustained bronchodilation over time. And that is one of the biggest and best message to take home with combination of medication. These slides, I'm trying to show that maybe the combination, and that is tiotropium, SF is salmeterol and fluticasone. The combination of three maybe is better on the bronchodilation side than each one separate, either tiotropium with salmeterol or tiotropium and placebo. So that is opening a little bit more the window for the newest inhalers, which is triple treatment in a single inhaler rather than separate. And how to deal with that is going to be a very important question that many studies need to answer in the future. Next, I'm going to talk about the emphysema, destruction of lung parenchyma. So we have oxygen, for which I'm not going to spend too much time in lung volume reduction. And on lung volume reduction, this is the idea. As you can see here in this CAT scan is that there is upper-low predominance, and when we have some areas of the lung that are destroyed and maybe non-functional. And they're probably causing some trouble to the other part of the lung, even to the heart, when they're active. So the whole idea came back in 1959, when Dr. Bryant again suggested that removal of those areas of the lungs that are not functional may help people breathe better. And what we found here is a combination of 4 slides, and that is the result of the NET trial, the National Emphysema Treatment Trial, which was published in the New England Journal of Medicine in 2003. And in what we show here, although it's a busy slide, I'm going to summarize. The use of lung volume reduction surgery will not work on every patient with emphysema. So I rearranged one of the graphs from this very important study into a 2x2 table. Upper-low predominance, non-upper-low predominance. Low 6-minute walk test as less than 150 meters, and high 6-minute walk test as more than 150 meters walk. And what we found here is that only the group that have upper-low predominance and low baseline exercise capacity are the ones who will benefit from surgery. And this is graph, what you can see is the probability of death. So with medical therapy, they are more likely in a 5-year period to die compared to the surgery after an initial period of death, which is otherwise understood and consequence of peri-op complication after such a surgery. Nowadays, we're exploring the possibility of doing bronchoscopic lung volume reduction, and I'm not going to dive into that topic, but it's a very important one because the whole idea is, can I do lung volume reduction without the complication of having the surgery? And we have seen good results, although with mixed picture. What about lung transplant? And lung transplant is being reserved for those unique cases that meet certain criteria. So one, COPD comes always with comorbidities for well-selected patient where there is no age limit. What we have seen in this graph, if from the International Society of Heart Lung Transplant, the proportion of patients over time that have received lung transplant. And what you can see in the lower curve, which is in blue and dark blue, is the patient with COPD. And a majority of patients who receive lung transplant are patients with COPD. However, this is a small proportion per year, around 1,000 in the world compared to the millions of patients who have COPD. So a well-selected patient who can have access to this kind of therapy, but it's something always to take into account. So how to approach this complicated combination? So we have inhaled corticosteroid, ICS, LABA, LAMA-LABA, LABA alone, SABA short-acting muscarinic, LAMA, or phosphodiesterase inhibitor. So many years ago, we only have two options. Right now, we have too many options in combination, and we need to have a more systematic approach in order to better treat our patient. Where to go? So this is a proposal. There have been changes in the guidelines, and the guidelines still trying to make expert recommendations. So I will suggest the following. What we don't go in and say, one, we're going to use severity of obstruction and symptom in a step-up approach. So for patients with moderate COPD defined by the level of obstruction, which is the FEV1, more than 50% of predicted, we'll do always lifestyle modification, smoking, exercise. We spoke about that. We start with a single bronchodilator treatment. And if the symptoms are not improved, then we do a step up and we add a second bronchodilator, we check adherence, and we consider the use of inhaled corticosteroids. And then, if that doesn't work, triple therapy and maybe phosphodiesterase inhibitors, and I will go a little bit deeper on that. The second aspect is for patients with severe COPD, probably we need to go and be a little bit more aggressive. And that time, of course, lifestyle modification, smoking, 2 drugs therapy to start with. If that doesn't work, then we go to triple therapy and phosphodiesterase inhibitor if that is contemplated and applicable. That is by severity of obstruction, but also by pheno and endotype. What I mean about that, we saw somewhat this graph and we have emphysema. For the pure emphysema, we have the following option. I will start with a LAMA or LAMA-LABA and then approach, and that will depend on the severity of the obstruction. Of course, for emphysema, CT scan is very important because that is how we identify the emphysema. And at the same time, we'll say, is this an upper-low predominant distribution of the emphysema? If so, then a 6-minute walk test is warranted, and we may consider yes and no lung volume reduction surgery if there is a upper-low predominant. Of course, oxygen if they meet criteria. Careful for those patients with emphysema and no obstruction. If they are symptomatic, treat them, and treat them with a single bronchodilator and then step up. Assess for oxygen for symptom during exercise is going to be very important. The next category is patient with emphysema due to alpha-1 antitrypsin. And although this can slow down, and there's mixed picture, we may slow down in density of CT with the augmentation therapy for alpha-1 antitrypsin. The next category is going to be those patients with obstruction would have a COPD asthma combination, and that sometimes has been labeled as ACOS. And here, because of this combination, we will suggest to start with an inhaled corticosteroid combined with LABA as the first choice in those patients. And for those with eosinophilia, and that is something that has been defined as more than 200, more than 300 cells per microliter, Mepolizumab recently has been published as potential treatment for those well-selected patients. Then we have the chronic bronchitis patient. And for those, I will start with a LAMA-LABA and then add on ICS if it's necessary. And those are to treat more of the chronic bronchitis. It's going to be more sputum, dyspnea, and a lot of phlegm. If there is bronchiectasis, I will say careful with the inhaled corticosteroid, especially bronchiectasis with repeated infection due to the risk of developing pneumonias. For those with diabetes mellitus and obesity, roflumilast can be a good option as well for them. And then we have the never smoker with airway obstruction. For those, I don't think we have a very good idea how to treat them. However, we have to recognize them and also use inhaled bronchodilation as well. And of course, we have to assess for oxygenation. We have to assess for smoking cessation. So this is a little bit of phenoendotype and by severity as approach for the different type of treatment. One very important point is acute exacerbation of COPD. What about acute exacerbation? What is important? In this slide, I'm going to talk and show you that acute exacerbation do matter. It's very important. And what you can see here is the probability of surviving on the y-axis and on a follow-up study of 60 months of 5 years. And what you can see here is there are 3 very well-differentiated curves. The green curve is for patients with COPD who do not have an exacerbation in the last year. The yellow line shows the survival curve for those patients who has 1 or 2 exacerbations require hospitalization in the previous year prior to start the study. And the red line is patient with more than 3 exacerbations in the previous year. How we determine exacerbation? Very simple. Ask your patient, did you have any exacerbation? Have you been hospitalized in the last year? What is an exacerbation? It's an increase in the symptoms, production of phlegm that require augmentation of the therapy, or more severe, which is the ones that require being hospitalized in the hospital. This is very important because, as you can see here, it does affect mortality. So what we have learned about the treatment of acute exacerbation in one study is that the combination of inhaled corticosteroid with long-acting beta-2 agonist, there is a reduction in the number of exacerbation in a follow-up of 3 years. So that happens also with long-acting muscarinic, and it's also happening now on the triple treatments when it's combination of inhaled corticosteroid, LABA, and LAMA. So use your bronchodilators and triple therapy on those patients who are frequent exacerbators. What about other treatments? And this is a very interesting study that was published in 2011 with the use of azithromycin, an antibiotic, on a dose of 250 milligrams a day, every day for a year. And what we can see is that there is a significant reduction in the number of exacerbations, not only on the number, but also days for the first exacerbation after entry to the study. The only problem here is that we need to assess for hearing acuity, as azithromycin can affect hearing acuity. So that is another alternative for patients who are maximized on bronchodilators and use of azithromycin. And the big question is going to be, do we need it on a daily basis, or can we use it 3 times a week as it's been used in other type of diseases that is open to research. The other question also is to balance that with the resistance of bacteria and the use of this widespread use of long-term use of antibiotic in a large population. The last point also on exacerbation is going to be the use of roflumilast. And roflumilast is a phosphodiesterase inhibitor and not only helps with bronchodilation, as you can see in this graph, and this is the FEV1 over time compared to placebo, but also there is a 36% reduction in the number of exacerbation. Problems? GI side effects. And this is also a medication that is better suited for chronic bronchitis with a lot of sputum production, and at the same time patients with obesity and diabetes. Then another point is supervise and correct the use of inhalers. Why? Well, we need to understand the drug delivery system. there is always a balance between all the medication that I'm speaking right now. There are medications that have a lot of receptor throughout our body, so we need to use it locally, otherwise we'll have a lot of side effects. So beta-2 agonists are not unique receptor to the lungs, and are not unique receptor to the smooth muscle of the airway, the same for the anti-muscarinic medication. So we need to deliver medication locally, and the best way to do that are 4 types of delivery system. Metered-dose inhalers, we're very familiar with that, and this is under pressure. We have a liquid and we spray and we get an inhalation with that spray. Dry powder inhaler, mist, there are newer ones, and nebulizer. Let me quickly show you, and this is the MDIs or metered-dose inhalers. And what you can have here is 3 pictures. One where the individual is using directly the inhaler through his mouth. 2, the patient or this individual is separating from his mouth. And 3 is the use of a spacer. And this is very important because that has to do with the technique. With this individual on the top left side, what we have is that there is more deposition of the medication in the oropharynx and the stomach, as seen in its very old study where you can see radio tracer when you radio label the MDI and you take pictures with a gamma camera. You see that after the actuation of the MDI, most of the medication will stay in the oropharynx and in the stomach, less in the lungs. If you use a spacer, which you can see on your right hand, is less deposition in the oropharynx, more deposition into the lung, and less in the stomach. So the use of a spacer is very critical in order to have the right deposition of those medications in the right place. The second is dry powder inhalers. Those are medications that are being used where the powder, it's a fine powder that can be inhaled and deposited into the lower part of the airways. And that is a great methodology where there is not much coordination. However, patient needs to be able to generate some inhalation flow. So a patient with severe obstruction may not be able to really use this medication. This is a mist inhaler, and here essentially is a combination between the powder and the more passive with the MDI, and the patient inhaled directly from this device. And the mist is directly inhaled. The patient needs to create an inhalation. And the last, which most of you may be familiar, are the nebulized system, and it's the nebulizers. And the nebulizers are effective. They create not as small particulates as you can see with the MDI, and therefore we need to have much larger dose and a longer time in order to deliver, but they're probably effective as it's a more passive on the side of the patients, and that is good for patients who have poor hand coordination and at the same time do not perform good technique. And now in the market, there are a lot of new products coming in the nebulized form. So let's go with question and answers. One of the first question is, when is pneumococcal vaccination recommended in patients with COPD? I will say A, pneumococcal vaccine is indicated in COPD patients 65 years and older. B, in smokers and COPD patients 19 years and older, only if they quit smoking. Any age, and PCV13 and PPSV23 can be given together. The answer is, it's yes indicated in smoker and COPD patient 19 years and older. And I can refer to the slide when we spoke about the CDC recommendation. For every patient, they are a high risk by being a smoker or having a chronic obstructive lung disease or chronic lung disease to develop pneumococcal pneumonia. So after age 19, we can start with the PPSV23. We can wait 1 year and then reinforce with a PCV13, and then we can reinforce after they reach age 65. Second question, bronchodilator does improve the rate of decline of FEV1 over time? A, only ICS have shown to shown an improvement in the rate of decline. B, only antimuscarinic inhalers have significant improvement in the rate of decline of FEV1. And C, bronchodilators improve lung function but does not modify the rate of decline in FEV1 or forced expiratory volume in the first second. And the correct answer is C. So we have been able to improve symptoms, exercise capacity, improve quality of life. However, the rate of decline for those patients with a faster rate of decline or mortality has not been affected by the current treatments with bronchodilator therapy. I thank you very much for your attention, and this is some of the references that I suggest to go and use for this lecture. Thank you very much.